Vamos a invitar al doctor André Abreu para que nos hable sobre la terapia focal, una opción para el control del cáncer de próstata con preservación de la potencia y evitar la incontinencia urinaria.
Good afternoon. Thank you again, Dr. Sotelo and Juan team, Dr. Galan, for the kind invitation, for having me here. So I will talk to you about the focal therapy for prostate cancer, which is an alternative for the standard of care is radical prostatectomy, radiation, radical treatments, with a good cancer control and preservation of the potency and continency. Now, the best patient, or most of us would agree that the best patient for focal therapy would be patients with intermediate risk disease, Gleason 3+4 or 4+3, mostly 3+4. But there are some patients that are on active surveillance that would be candidate for focal therapy, and some patients with high-risk disease that would also be candidate for focal therapy. Now, in the review of the literature from 10 years, 1996 to 2015, there were published 37 original articles, 3,200 patients, and only 9 articles reported 175 patients. That means only 5% of all of these patients was treated from high-risk disease. Most of these patients were treated they had low-grade, low to intermediate risk disease. Now, what we can take from this initial series? This initial series, they were more for safety and feasibility and exploring the techniques and technologies. What we can tell is that serious adverse event, 3% only. So complication profile is very low. Continency, very high, 93 to 100%. You may say, I'm a very good surgeon. I can tell that my patients are all continent. It's tough to believe, but even if we take, we need very good surgeons across the world to achieve this, which is pretty much routine for focal therapy. Potency, 80% to 95%. Again, it's very difficult. Of course, these patients are selected, but it's very difficult to do radical treatment, radiation or prostatectomy, and have these continence and potency rates. And fistula, which is the most, let's say, terrifying complication posed for focal therapy, is very low. 0 to 2.4. Actually, the most recent series, this is even lower and lower. We will see. I will show you. So that was for HIFU. This is the same for cryoablation. So even if different technologies, different surgeons across the world is still similar outcomes in terms of functional outcomes and complications. Now, the question is, now, focal therapy is safe, it provides low detrimental impact on continency and potency. The main critique was that many of these patients would be managed with active surveillance, that they would not necessarily be treated. They were low to intermediate risk disease, so focal therapy actually is not good. You're just treating patients that don't need to be treated. However, if we start looking at the most recent publications from 2018, 2019, then we will see here 1,000 patients from London. This is a single series from one single center. 80% of the patients had grade group 2 or higher. Now, we see how Gleason 6 was higher from the beginning, and then it was decreasing and decreasing, and how Gleason 7 is increasing and increasing. So this is a trend in response to all of these critiques that now we are treating patients with higher risk. Keep going. What are the outcomes of the focal therapy, focal HIFU for intermediate and high-risk prostate cancer? This is a manuscript, again, published in 2019, Journal of Urology. This is a series from Canada. 3 institutions, they did a HIFU in 150 patients with bilateral biopsy proving unilateral cancer. Again, 89% of the patients had at least intermediate risk disease. So now you're not talking about low risk disease, you're talking about intermediate and high risk disease. Same indication of the patients that you are doing prostatectomy or radiation. And they did partial gland ablation, several different templates, focal, hemi, or hockey stick. They biopsy half of these patients, 37 of them had cancer on follow-up biopsy. Salvage treatment was performed in 25% of them. However, vast majority of them had repeat HIFU. This is characteristic of ablation. Ablation can be repeated, and we have to talk to the patients up front. There is a chance for recurrence, and we can repeat the treatment. It's different from radiation that you can't repeat, but ablation we can repeat. So in 2 years of follow-up, whole gland treatment was avoided in 81% of the patients. You say, okay, this is too short follow-up. It's 2 years only. Let's see how this thing goes moving forward. Again, complication profile. Most of the patients have low-grade complications, and potency and preservation, potency 90%, continency 95%. Keep going. Now, we are talking about 600 patients from UK. This is a multi-century, several centers, prospective registry from 90 centers from United Kingdom. Patients underwent MRI, systematic biopsy, or template biopsy, and they included here Gleason 6 to 9, so you're talking about high-risk disease. They included here patients with T3B, PSA up to 30. So these patients are the same patients you are treating with radical prostatectomy or radiation, right? Not, when we look into this, intermediate and high-risk disease, 85% of the patients. So what we are looking is a shifting from low-risk prostate cancer to intermediate and high-risk prostate cancer. Okay. Now, what are the endpoints they used? Radical transition to radical or systemic therapy, metastasis or cancer-specific mortality. And they used several different templates. Some patients had contralateral Gleason 6, small volume, this was allowed. And in 5 years of follow-up, median follow-up is 6 years, right? Not 6 years, 5 years of median follow-up. 5 years of follow-up. Failure-free survival, 88%. Low risk, 96%. Intermediate risk, 90%. High risk, 85%. So now we are talking about larger cohorts, multi-center study, prospective, high-risk patients, intermediate to high-risk patients, and we have these results. Keep in mind that, of course, high-risk patients, you have higher rate of recurrence. This happens with any treatment. This happens with prostatectomy, with radiation. Any treatment you do, patients with high risk, they will have high recurrence rate. And that's what they found. Higher PSA at baseline and T3 stage patients have higher risk of recurrence. Not surprised. Still, low complication profile, rectal fistula, 1 in 600, 0.2%. The other rectal fistula here. So there's 2 rectal fistulas in this series of 600 patients. So as we discussed, fistula as experience improve, technique and technology, fistula rate is lower and lower. Still continency, 98%. Now, how about focal therapy with cryoablation? So that was HIFU. How about cryoablation? Again, another series from UK. It was published in 2019, 122 patients, and here they included only intermediate and high-risk prostate cancer. There is no low-risk patients. Intermediate and high-risk prostate cancer only. Most of the patients had anterior tumor. This is a trend. For posterior tumors, we are doing more HIFU. For anterior tumors, we are doing more cryo. So 80% of these patients had anterior tumor. Follow-up was still 3 years, or 2.5 years. And the endpoint they used was the same. Transition to radical treatment, transition to whole gland treatment, systemic therapy, metastasis or death. What are the outcomes? 3 years, failure-free survival, 90%. Potency preservation, 84%. Incontinency, 0. Some low-grade side effects, urinary retention is 4%, infection, UTI, 10%. So all of these managed conservatively. Now, we look into our series as well. This is our series from USC and some colleagues. We look at the hemigland cryoablation for low, intermediate, and high-risk prostate cancer. We included 160 patients. 82% of them had intermediate or high-risk disease. So again, we are talking about significant cancer. And primary endpoint, similar as the other publications, similar to the manuscripts I just talked. Transition to radical therapy, initiation of systemic therapy, metastasis of prostate cancer-specific mortality. We also look at biochemical failure, defined by Phoenix, clinically significant cancer and radical treatment, free survival. So this is the result. In 5 years, 83% of the patients were free from failure. So treatment failure-free survival is 83% for intermediate disease and 78% for high-risk prostate cancer. So this is very reasonable. If you consider radical prostatectomy, you have probably in a good surgeon, if they do surgery on these patients, they will have 15% positive margins. Some other patients on top of this will have biochemical failure. So I would say in 5 years or so, their treatment of failure or need for salvage would be pretty similar. And if you do radiation, it will be also. Now, again, be very careful. We are saying that high-risk disease patients, they are high risk because they have a high risk of recurrence. Patients with PSA density more than 0.25 from the baseline have increased risk of recurrence. PSA density is a very good marker. PSA density, some series report PSA density as strong as Gleason score to predict recurrence and to predict worse oncological outcomes. Similar happened with clinically significant failure, PSA density again, and treatment failure-free survival. So if you have a patient with high PSA density from the very beginning, be careful. Potency, this is from our series, 73% of the patients were potent after hemigland cryo, and continency, 97%. Again, several series, different technologies, different surgeons across the world report very similar outcomes, and now we are talking about larger cohorts with longer follow-up for intermediate and high-risk patients. This is our series, very recent, from HIFU. We were one of the first centers starting HIFU in the United States, was the first academic center starting HIFU in the United States in 2015. December of 2015 was the first case we did. Of course, we do not have a longer follow-up, but we have the results of the first United States series for focal therapy using HIFU. Now, we are reporting here consecutive patients that underwent hemigland HIFU ablation in the United States. Primary endpoint is the same. Radical treatment, systemic therapy, metastasis, prostate cancer-specific mortality. However, as this cohort is young, we have only 2 years of median follow-up. We also included, to be fair, positive biopsy within this criteria. Now we see 100 patients. 70% of them have intermediate or high risk prostate cancer. And what we see is in a follow-up of 2 years, of course, we have a short follow-up. We start doing this in 2015, so we have 4 years total period, 2 years of median follow-up. Radical treatment-free survival, 92% for low-risk prostate cancer, 90% for intermediate and high risk. Treatment failure, including biopsy, patients that had positive biopsy, 75% and 72%. Again, these numbers, specifically this one, is very reasonable for patients with intermediate and high-risk disease. Now, one concern that we have when we are treating high-risk patients is that the treatment itself, if it's properly delivered, properly selected patients, there is no data proving that a Gleason 9 is more resistant to cryo or HIFU than a Gleason 6. The cell, the tissue itself, should be killed if the treatment is properly delivered. However, these high-risk patients, they have bad behavior. The disease is different. They might have micrometastases, they might have extraprostatic extension that we can't capture on MRI or on nomograms. So what we are offering for these patients is patients that have a higher risk of lymph node metastasis on nomograms using MSK, Briganti, or Parting tables. We offer them at the same time lymph node dissection. So this is based on the NCCN guidelines. When you have a patient that you do prostatectomy, you offer pelvic lymph node dissection if the chance of node metastasis is more than 2%. We offer for our patients, and that's what you're seeing here now. This is the XI robot docked. This is the HIFU probe, and at the same time that the surgeon is doing lymph node dissection, another surgeon is doing the HIFU. This is concomitant, both at the same time. And then you say, I don't have the XI in my hospital. That's fine. You can do a side docking. Here's the SI. In the side docking, you see the rectum is free and the probe is inside the rectum. The side docking is very common for gynecologists and colorectal surgeons. So you can perform the same prostatectomy with the side docking. Now, for this series, we reported like 8 patients, and one of them that had a Gleason score 7, 5% chance of lymph node invasion, he actually had 2 positive nodes. So when we talk about treating high-risk disease, we have to be very careful. I'm not coming here and say, oh, Dr. Abreu is saying that we are treating focal therapy we're applying focal therapy for high-risk prostate cancer for every single patient. No. We at USC, we are Center of Robotic Surgery and Excellence in Robotics. However, there are patients with low volume, low PSA density, low volume Gleason 8, and low PSA density that they are still candidate for focal therapy. So one critique that also has with focal therapy is that there is no clinical trial comparing focal therapy with radical prostatectomy. Clinical trials, surgical clinical trials are very difficult to perform because it's a completely different concept. A patient that wants robotic surgery is not the same patient that wants HIFU or cryoablation. So doing these trials is very difficult. It's different when you do a trial that you take a pill A or a pill B, right? The patient is fine. You can apply the same thing. There is no surgery involved. It's different. This group from Norway, they have this trial, this clinical trial.gov, focal prostate ablation versus radical prostatectomy. They accrued 79 patients, 30 for HIFU and 30 for radical prostatectomy. Surprisingly, at least for me, this is a group from Norway, they could not accrue more patients because the patients that were selected or that was randomized for radical prostatectomy, they wanted to cross over to focal therapy. So actually, patients in this series, they did not want to undergo radical prostatectomy. So just to conclude, focal therapy is safe and feasible. This is from the very beginning, as we discussed. It's reproducible. It's performed in Mexico, it's performed in South America, it's performed across the world. Functional outcomes are excellent, continence and potency, as we showed. Cancer control is something that we need to define, but as I showed you, in 5 years, treatment failure-free survival is similar as radical prostatectomy or radiation therapy for selected patients. Larger cohort with multi-center studies are now presented. Longer follow-up, up to 5 years, is now presented. Low intermediate disease, low and intermediate risk disease, mostly intermediate disease looks like be a sweet spot, but we see a trend for patients from intermediate and high-risk disease as well. Thank you. Any questions? Any question? No? Yep. In our center, we do hemiablation. At USC, we do hemiablation. Why is that? There are some physicians that they do true focal plus margins, some physicians that do quadrant, and some that do hemi. There are, in the literature, three manuscripts from the same authors, same machine, same author, same institution. Difference is, one manuscript, they did hemiablation, the other one, they did quadrant, the other one, they did true focal. Biopsy recurrence rate, 0, 7, and 15. So complication profile, very similar. So if the complication profile is similar, oncological outcomes are better with hemi. So that's what we do hemi. If you want to do true focal or quadrant, you have to be very careful and select the patients very well.